are extremely delighted to have our, clinical lead for mental health back with us, Dr. Joseph Omofuma. For those of you who may have missed part one, you can watch it on the YouTube, and we will put the link in the, chat box. But over to you, Dr. Joseph, and thanks for giving time.
Thank you. Good morning, Charles. Good morning, everyone. Apologies for joining in a little bit late. Right. I'm glad to be here this morning. We want to quickly look into the subject of psychosomatic disorders. And like Charles said, if we missed it last week, we can catch it up. But I'm going to just do 4 things today. We'll recap very briefly what we talked about last week. We will redefine a few things, including the psychosomatic theory. We will look at a few examples, and then we'll go on to treatment. What I've tried to do today is to try to bring the subject matter very close to home. I'm going to try and simplify it. I thought, well, in my opinion, because I think I'm my own worst critic, I thought last week was a bit technical. So I'm going to try and break it down a little bit further and just try and make it simple, because I'm aware of the fact that I want us to be able to keep it so simple that you can take this and hopefully use it in your own regular day-to-day life. So I'm in my kitchen, so forgive me, it's Saturday and I'm and I'm chilling, like my teenagers would tell me. So right, so let's get into it. Can I share my screen, guys? So we've got psychosomatic disorders, part 2. Let's see, I think if you could make me the co-host, that would be great, and I can share my screen. Otherwise, Charles, you've got my slides. I sent it to you early this morning, actually.
Right. Could we?
Yes, you're already co-host.
Okay, why is it not letting me share? Host disabled participant screen sharing. But we'll work on that in the background while we start talking. So what did we say psychosomatic disorders are? We said these are disorders of the mind that basically show up with...
Could you try resharing again?
Certainly. There we go. Okay, so that's me, in case some people don't know. Okay. We said that these are disorders of the mind that show up with physical symptoms. It's 2 words, psycho and soma. So psycho is mind, soma is body. And so basically these are disorders of the mind that end up with physical symptoms. It's very important to understand psychosomatic disorders, because a lot of what happens in our bodies are influenced by what happens in our minds. And if we remember, I said that regarding the psychosomatic theory, that basically if you have a situation where the brain, and this is established, a situation where the brain affects all the different organs and everything that happens around the body, the psychosomatic theory is such that it's been proposed as the fact that what happens in the mind can equally have an effect in the body. Now, as a way of disclaimer, this is an area of medicine that is still being developed. And let me be bold to say, I always say that there's still a lot of room for research, put it that way, in this particular area. All right. So that's basically what it is. So what are some of these symptoms that we experience? You know, we mentioned them last week, so I'm doing a quick recap. We talked about the fact that there are very common things that happen to us on a day-to-day basis: fatigue, poor sleep, aches and pains, such as muscle pain, back pain. I also mentioned that 20% of all pelvic pain, for example, chronic pelvic pain, is undiagnosed. There's just no reason for it. Medics can't find anything. They've done all the scopes. They've done all the investigations. High blood pressure, very common. Trouble breathing, indigestion or upset stomachs, headaches, migraines, erectile dysfunctions, vaginismus, things like that. These are all very common symptoms that you get as a result of psychosomatic disorders. Going further along, I will try to distinguish between psychosomatic disorders and disorders that you just make up, because psychosomatic disorders are not things that are just happening in your mind and, you know, maybe somebody will think that somebody made it up. No, the symptoms are real. The symptoms are real to the person who's suffering it. The symptoms are present. The symptoms are so to the point sometimes that they're debilitating. Unlike factitious disorders where someone's making it up in order to pretend for some gain or attention and things like that. So psychosomatic disorders are real. The difference is that in psychosomatic disorders, for example, where you have abdominal discomfort and things like that, if you were to do a scope, like an endoscope or a colonoscopy or things like that, you don't find anything going on. You don't find an organic cause. You don't find any specific cause. So the theory behind that is that it's what's happening in our minds that's affecting what's going on in our bodies. And there's a lot of manifestations of that, as we have seen. All right. So let's move on swiftly. Now, I felt in order for us to get a broader picture of what psychosomatic disorders really do, there are five, at least in the UK, there are five major areas of mental health issues that we tend to see on a daily basis. These are the big five, in my opinion, and in many people's opinion. I mean, you have other things that are not included here, like eating disorders and things like that. But these are the big five things that affect us on a day-to-day basis. Why are these important? The first two tend to contribute to producing psychosomatic disorders or psychosomatic symptoms. Anxiety, depression. I think I spoke some time back in the previous about the fact that these are very, very common. Research suggests that 1 in 3, 1 in 4 adults in the UK will suffer with anxiety or depression in their lifetime at some point. And we've defined that. It's in previous talks. We're not going to go into that. But these are the five major mental health issues. And it's important for us to understand them, as it were, or to get an understanding. Anxiety is a disorder of fear. Anxiety is a disorder of fear or anticipation of something bad happening to us. And under this simple term anxiety, you have several other disorders. You have post-traumatic stress disorder. You have generalized anxiety disorder. So there's a lot of other things. In fact, if you go to the ICD-10 classification, there's almost a whole page of different types of sub-anxiety disorder. So when I say anxiety, it's not, you know, the anticipation you get when you see your son climbing on a stool and there's no support, or in my case these days, when Man United is about to play, you don't know which team is going to show up or whether they're going to perform or not, you know, but that's not what I'm talking about. We're talking about a real issue here, a feeling of foreboding, a feeling that something bad is going to happen to me. And they come in many, many different cadres: generalized anxiety, post-traumatic disorder, all sorts of different things, but it's a disorder of fear. The underlying or the overlying symptom you get is fear. And that's what overshadows it. Sometimes, as a matter of fact, you hear the person saying that, I don't even know why I'm afraid, but I'm afraid. I don't even know why I'm anxious, but I'm anxious. Those are typical anxiety symptoms, where even the person who is experiencing it cannot for the life of them say, this is the reason why I'm, you know, if you had a specific thing, sometimes you can say, okay, it's because the sky is yellow or because the sky is blue. No, sometimes there's no specific thing and it's just there. Depression, on the other hand, is a disorder of mood, all right, especially low mood. And we defined this very nicely previously, basically low mood, which can often leads trigger off to other things. The interesting thing about mental health issues is that a lot of these symptoms are interwoven with each other, even though they stand alone. So let's just understand it that way, that anxiety can show up as part of psychosis, as part of dementia, as part of bipolar affective disorders, but on their own, they are disorders in their own merit. Depression is a disorder of mood, all right, especially low mood. Bipolar affective disorder, which is the new name, it used to be called manic depression in the past when I was a student, many moons ago. Bipolar affective disorders are, you have mania, you have hypomania. The most common one is, sometimes, let me put it this way, the most alarming one is mania, where you have a situation where an individual is the opposite of depression. Depression is low mood. People are withdrawn. You don't want to participate in things. You don't want to go out. There's a fear of things happening to you. Mania is the exact opposite. There's no fear. There's no inhibition. People, they talk very loud, very quickly, very forcefully, to the point where there's a symptom called a word salad. They're talking sometimes, and it's not even making sense. They're just talking. You also have a situation where an individual is giving away their things. They just wake up one day and start giving away all their stuff, and you think they're generous, they're not. It's a symptom of, it's possibly an underlying symptom of bipolar affective disorder, where for no reason. I mean, many of us are very generous, and it's a very Afro-Caribbean thing to be generous and hospitable. That's not what we're talking about here. We're talking about an excessive form. Like I said in one of my earlier talks, most mental health symptoms are an excessive form of what would be considered to be normal. So that's bipolar. Psychosis, it's difficult to define psychosis, but it's usually characterized by hallucinations, either visual hallucinations or auditory hallucinations, where you are seeing something that nobody else is seeing. You're hearing something that nobody else can hear. The main thing with psychosis is that the individual is disconnected from the real world. So you and I, for example, may have dreams or fantasies and things but you can know, for example, recently I've been dreaming of the beach. I want to go on a holiday by the beach, influenced by my kids who love the beach. Now, I can distinguish that I'm in Manchester and it's raining, even though I would love to go to the beach. The person who has psychosis, especially the biggest form of psychosis, schizophrenia, cannot distinguish that difference. They can't tell the difference. They actually think they're on the beach. And you cannot shift them away from that line of thinking. That's the difference. So we need to be able to understand all these things in order to be able to put psychosomatic disorders in perspective. Dementia, many of us, I think perhaps in the future, guys, we would need to address, if it hasn't already been addressed by my colleagues who are psychiatrists or mental health practitioners. Psychosis and dementia are things that I think on their own merit, we need to examine them carefully. Now, why are these important? Anxiety, depression is hardly ever dealt with by a psychiatrist. The big two or the big three that psychiatrists tend to deal with are bipolar and psychosis. Dementia, okay, yes. They tend to leave anxiety and depression to general practitioners like myself, or counselors or therapists and all of that, except when those illnesses become so bad that maybe self-harm is involved or other things, or they're not responding to medication, etc. It's very telling in the sense that anxiety and depression is so common and generally easier to manage that the psychiatrists tend to leave that to other health professionals who are capable to deal with that, except in severe cases, which is fine, which is great, which means that there are more people who can deal with more things. So why are we talking about all this? And I said anxiety and depression tend to be the most likely cause to psychosomatic disorder. They are big contributors. All right. So I mentioned this before as well, that there's a huge difference between psychosomatic disorders, which I've shortened to PSD, by the way, psychosomatic disorders and factitious illnesses. So factitious illnesses are It's a situation where an individual just decides to make up an illness in order for some sort of gain. One of the commonest reasons that people do that is for attention. Maybe they're not paying them enough attention at home, teenagers or even elderly people. Or unfortunately, again, it's more common in women. You make up the symptoms so that you gain attention, so that you become the center of attention. And you know that there's nothing wrong with you. That's the difference. The individual is aware that there's actually nothing wrong with them, but yet they are making up the symptom. And another good example is people who want painkillers. Some painkillers make you feel very nice, so I'm told. Things like morphine and things like that, codeine. So they make up these symptoms so as to so you can get something. That is not the case with psychosomatic disorders. With psychosomatic disorders, the individual feels the symptom. They can feel it. As a matter of fact, they don't have control over the symptom. If they could get rid of the symptom, they would. Whereas with factitious disorders, it's purely something that the individual has made up in their mind, and they are aware that they have made it up. Right. So that was a little brief overview of what we did last week, catch up with a few things and try to break it down a little bit more. Now, we said last week that the same way that the brain controls different body organs, and we went into town to talk about that last time. That's the way the mind can control our body. So now let's going deeper into psychosomatic disorders. I'm going to talk about three main ones. We won't have time to thrash out all of them individually per se. I think I said at the very beginning that this subject is very big, is very wide, and I would feel it's an injustice just to run through it or to minimize it, because people who suffer with this are going through a lot of difficulty, and often they are stigmatized because they're going to the GP several times or to the doctor several times. They've told their partners or their friends and their families that I'm having these symptoms. All the tests have been done. Nothing can be found. Frustration begins to set in. And in typical African or Caribbean fashion, we begin to think that maybe it is spirits who are causing all these things. So I take this very, very, very seriously. Because I have seen the individuals who are going through it, they are actually suffering. It can be debilitating. It can be something that is really, so the symptoms are real. Let's just go through three big ones. I promised last time that I would give examples. There are three big ones that we will look at. We'll try and go through them as much as we can and then take some questions. So number one, gastrointestinal disorders, GI disorders, or gastrointestinal psychosomatic disorders. Big. Gastrointestinal, big, big, big. Second one is chronic fatigue syndrome. And then the last one is fibromyalgia. Somebody asked a question last week about fibromyalgia. Apologies to that person. I think last week I was in flu clinic and I was rushing. Fibromyalgia is classed as a psychosomatic disorder. So we want to look at those three and try and make some sense or get some ideas. Please post your questions in. I'm being told to tell you to post, they're telling you to post questions in so that we can look at a few things if there's time to just try and clarify and shed some more light on stuff. Okay. Right. So let's look at examples. Am I sharing? I'm sharing. Okay. Functional GI disorders. The first one that I mentioned is gastrointestinal disorders. Remember, the last time I spoke to us, we talked about functional disorders versus organic disorders. Now, these are medical terminology. It's functional because we can't find any specific thing that's causing it. An organic disorder is something that you put your camera there, you can see there's a polyp, or you can see that there's something there that's actually causing such and such a person's symptom. But when something is functional, That means we can't put a finger on why this person is experiencing these symptoms. However, I want to be able to break this down a little bit, because one of the mistakes that we have made, and even I have made severally in the past, is we class all functional GI disorders as IBS, irritable bowel syndrome. Now, last time I spoke extensively about irritable bowel syndrome. Many of you know it's basically characterized by abdominal cramps, abdominal pain, bloating. Sometimes you may have diarrhea. Sometimes you may have constipation. You may even have some skin issues like rashes and things like that. The thing with psychosomatic disorders is that what we find is that there's usually an underlying mental health disorder. That's one of the things I want to point out. Usually anxiety, depression plays a huge part. In almost 99% of people who have psychosomatic disorders, there's an underlying thing. And that's why the bane of the treatment these days is actually function more towards psychotherapy as part of the treatment plan. But we'll come to that in a minute. So I've said that not all GI disorders are IBS. This is what the point of this particular slide. Now, I used to think everything was irritable bowel. Why do we all think it was irritable bowel? Because it was very common. We had a treatment for it. We know that it's caused by colonic cramps. There's a lot of research that's gone into this. There's cramps in the micro parts of the colon that give you these spasms that then cause the symptoms of IBS, usually associated with stress or anxiety, or when you are going through a rough patch. All established. However, that's not the only functional GI disorder. Other GI disorders, there's something called functional diarrhea. And this is why some of us, I in particular, have experienced this, where I've had a patient, they're having symptoms, I've treated them for IBS, they're not getting any better. The reason being is that there's a separate entity called functional diarrhea. Some of my older patients, they call it, that they said, I have a nervous tummy. Every time I get nervous, I have loose motions. Some of you may or may not recognize that in some of your friends and families. I remember very clearly then when I was writing medical school exams, and all of you, if you have been anxious or all of that, somehow you want to go to the toilet and all of that. But in people with functional GI disorders, it's greatly heightened and exacerbated. So it's not just that nervous, it's the older people call it a nervous tummy, but so but it's not just that nervousness that you get, it's much more worse. So there's this entity that happens where people have loose motions. We do all the tests, we send the camera down, we even treat them for IBS. The problem is the pathophysiology behind IBS is quite different to functional diarrhea. And so if you don't treat it properly, or if it's not properly diagnosed, what you find is that you're treating IBS, you're not getting any joy. Functional constipation is the exact opposite to functional diarrhea, where the bowel is clogged up. Now, with functional diarrhea, what you're getting is that the peristalsis, or the movement of the intestines, is too fast, and that's why the individual gets that those symptoms. With functional constipation, there is a slowing down of those intestinal functions, and then you get constipation. Again, it's different to IBS, because if you try and treat it with IBS medication, you probably make it worse. There's also an entity also now recognized called functional bloating. These are very important, because when you go to your general practitioner or when you go to your specialist, it's important to be able to speak to someone who understands this and can then specifically try to deal with it. They are difficult to treat, I must say. They're difficult to treat, but they're not impossible to deal with. My job is to help us recognize that these things are there and to see how we can begin to work through them. All right. So we talked about GI symptoms. Let's move on to chronic fatigue. It seems I'm rushing a little bit, but I just feel that I want to try and get through as much, so that if we have questions, we can have time for it. And if we close early, all the better. Africans are very good at closing late. Sometimes it's good to close early. Chronic fatigue, or as it used to be known, myalgic encephalomyelitis. All right, myalgic encephalomyelitis. The name chronic fatigue syndrome is better preferred by a lot of people these days because not everybody gets the symptoms of myalgic encephalomyelitis like it used to be called. This is a condition that is mainly characterized by extreme forms of tiredness. This is not your regular run-of-the-mill, I'm tired. You're basically, you're wiped out like, you know, like you've been fighting a war or you've been in a battle or you've been running a marathon or something like that. And the main symptom is, especially after exertion, you know, mild exertion seems to wipe you out. And again, our lovely health professionals and nurses will do your bloods, we check your iron levels, we check your vitamin D. All these things can cause tiredness as well, all right? We do all that. All of that is normal. We are really very tired. Now, the flip side of this is we need to be able to distinguish this between post-viral fatigue, which is a form of chronic fatigue syndrome. The difference is that chronic fatigue, you can't diagnose chronic fatigue until it has gone on for at least 6 months. So 2 days of tiredness does not buy you CFS or ME. You know, somebody says, I have ME, I've been unwell for four weeks. No, it has to be, I've been going on for at least 6 months. Also, there are other diagnostic criteria. The symptoms should be enough to be said to be debilitating. And the main issues here are malaise, or sorry, tiredness and poor sleep. You sleep and you're not feeling refreshed. There are lots of theories as to what causes chronic fatigue syndrome. Some of the theories include that, you know, maybe there was a viral infection, mainly viral. Most of the theories have been around viral. But the truth of the matter is we don't really know for sure. You know, when you think about pneumonia, we know that you can get strep, you can get staph, you can get other forms of pneumonia, tuberculosis pneumonia, and you treat that, you treat the pneumonia. Not the case with chronic fatigue syndrome. It's extremely difficult, and it's a new area in medicine where things are being discovered. Let me say this while we're on the subject. I have some friends, colleagues, good practitioners who don't believe that these things exist. They believe that, you know, patients are just making it up. It's all in their heads. But I've looked into this in greater detail, and I've looking at my patients, and the general consensus with a lot of health professionals is that these things happen. They're there, you know, and people are suffering with them. And it's important, I feel it's important for us to listen to people and to help them in these difficult situations, because some in psychosomatic disorders, the person who's suffering it does not control the symptom. That's the point I really want to drive home today. It's not something that you can turn on or turn off and decide that today I'm going to be tired. If you're doing that, then you don't have chronic, you don't have a psychosomatic disorder, or indeed MS. If you feel that, well, you know, it's raining, I'm not feeling up to it. People who have genuine psychosomatic disorders can't control it. So even when the weather is nice and bright and your favorite friend is out there or your favorite food is being served, there's just no energy, no motivation to be able to go out and do it. So some of the symptoms include post-exertional malaise, unrefreshing sleep, like I said. Now, this fog, concentration problem, lack of concentration, where, you know, the ability to process information slower. I've seen someone with this, and I thought they were making it up. But then I observed them for a period of time, and I found out that they were trying their best, you know? They were trying their best to do the stuff, but they just couldn't. They were not making up, you know. And so I think as a community and generally for us as medics, I feel there needs to be more recognition and understanding of these things, because not everybody is playing up and doing a factitious disorder. There are people who are actually suffering with this stuff. Of course, abdominal issues, bloating, nausea, light sensitivity, muscle pain, headaches, joint pains, sinus problems, sore throats, things like that. And the patient may feel, oh, why am I always having this stuff? It could be an evidence of chronic fatigue syndrome. Now, what I'm going to try to do before I lose my train of thought, is to summarize these and look at all the different treatment options as we go along. Is that okay? Just, I like to be quite systematic in the way I do things. Now, another entity that has been disputed for years, and I used to be one of those, I wasn't a believer, I must say, fibromyalgia. Fibromyalgia is a chronic musculoskeletal condition where it's characterized by joint pains and stiffness. But it's not just that, there's a bit more to it. There's fatigue as well with this, sleep disturbance, cognitive problems, memory problems, headaches, dizziness, problems with vision, jaw pain, nausea, even sexual dysfunction, period disorders, you know, lack of libido, skin problems. And the hallmarks of fibromyalgia as separate to chronic fatigue is the joint stiffness and pain. And you'll see when we come to looking at what the options of treatment are, because there are options of treatment, some not very effective, but options of treatment there are. See, one thing I should clarify is that there are many conditions that behave in a similar way to some of these things. I've given examples of this in the past. For example, an underactive thyroid can cause you tiredness. It can cause you to have weight gain. It can cause reduced libido. It can cause skin changes, lack of energy. So it's really important that if you feel you have any of these symptoms, I would suggest strongly that the first port of call would be to go to your health professional, your GP, your practice nurse, and to request some blood tests in order to rule out any underlying cause. That is really important, because you don't want to run the risk of having an underlying problem and you think it's a psychosomatic disorder, whereas it's something that is quite easily treatable. For example, with underactive thyroid, once you replace with thyroxine, you then find that, you know, the individual is actually fine and they're much better. Also, going back to the issue of joint pain, stiffness, lack of libido, the person or the individual may be getting towards menopause. And that's a big one. I think somebody very good person has dealt on issues around menopause. But menopausal symptoms are real, where you have hot flushes, night sweats, anger, irritability, mood swings. You see, the fact that you have mood swings doesn't mean you have bipolar. You know, some people think I have mood swings, so I have bipolar. No, that's why I said these disorders are, you have to be able to define them and diagnose them specifically. But with menopause, you have tiredness, you have skin changes, you have lack of libido, you have all the hot flushes, night sweats, anger, irritability, even low mood. So it's really important to be able to delineate and distinguish between a psychosomatic disorder, which is not caused by something underlying, as opposed to something like the menopause or thyroid or other conditions. In addition, especially with regards to fibromyalgia, there are lots of rheumatologic conditions that present in the same way like fibromyalgia. For example, rheumatoid arthritis. And there are many different categories of rheumatoid arthritis. You have rheumatoid positive rheumatoid arthritis, seronegative rheumatoid arthritis. You have osteoarthritis. All right. There's many different forms of arthritis that can give you all those kind of symptoms. Juvenile rheumatoid arthritis. There's lots of different ones. I did a paper once some time back on the different types of arthritis. There's different categories and different things. Somebody just says I have joint pains and they think it's arthritis. It's a little bit more than that. So the point is, I said all that to say this, that before we can say that it's a psychosomatic disorder, before we can say, you know, that it's mainly something that is in your mind that's affecting your body, there has to have been comprehensive tests. There has to have been extensive testing. And sometimes perhaps even with specialist input in order to be able to distinguish and determine that there's no underlying cause, and therefore this is now a psychosomatic disorder. Time will not permit for us to explore some of the spiritual angles that people have thought, you know, psychosomatic disorders could be caused by. I think we've done a session on spirituality and stuff like that. Now, what is the management of this? How do we deal with this? I'll keep it really simple. All of them, the three that I've discussed, functional GI disorders, chronic fatigue, and fibromyalgia, the list is not exhaustive, by the way. I just thought I'd bring the most prominent, the most common ones out for us to see and to sort of chew on and marinate on today. And maybe if there's time sometime in the new year, we'll talk about it a little bit more. I don't know. But one of the main things, the main thrust of treatment these days is cognitive behavior therapy. I must say, let me say publicly, I've told them privately, I'm really proud and I'm impressed with the counseling department of CAHN. They're doing a fantastic job. They have very trained, well-trained therapists and counselors. And, you know, I've seen some of their work and I'm really impressed with it. So I want to encourage you, if you're not taking advantage of that, please refer people, your neighbors and people around to them. They will help as much as they can. Now, the thing to say here is cognitive behavior therapy is not counseling. All right. Counseling has its place. Counseling is very important. Counseling is extremely useful. Cognitive behavior therapy is a form of psychotherapy. It's a specific form of therapy that you need to be trained up in, that is used to help with all of these psychosomatic disorders. One of the hallmarks of cognitive behavior therapy is to help the individual, number one, to challenge why they think the way they are thinking. Because you see, the psychosomatic theory, the whole idea behind the psychosomatic theory is that your mind is causing you to feel that you have these symptoms, right? So one of the hallmarks of cognitive behavior therapy is to help you to challenge, why am I thinking the way I'm thinking that way? So challenge the underlying anxiety, challenge the underlying, you know, the feeling of foreboding, the feeling of doom. I'm putting it in a very simplistic way, but it's not so simple. Some of you who have experienced CBT or who have family who have, you need about 8, 10, 16 sessions to unravel most of these things. But the aim of it all is to give the individual a coping tools, coping mechanisms that they can use to be able to deal with those things on their own. With regards to GI functional disorders, medication plays a huge role. With IBS, you have antispasmodics like buscopan, mebeverine, etc. Now, don't be offended or surprised if your GP or your specialist offers you an antidepressant or anti-anxiety medication. This is because this has also been proven to be effective in dealing with IBS. And there is no shame or there's no issue with taking them. I come across a lot of people in the Afro-Caribbean world saying, oh, they put me on antidepressants. They're evil people. They're not. We are not. Because if you had diabetes, for example, and you were offered medication for diabetes, you would take it without much question. Well, most of us would. Because I had a lady ringing me once saying that she wanted to phone her pastor to confirm if she was okay to take blood pressure tablets, and I nearly collapsed in my chair. Fortunately, I knew who the pastor was. I cheated a little bit. I phoned the pastor up and said, a church member is going to ring you about blood pressure tablets. Please tell them to take the blood pressure tablets. All right. So there's a bit of a stigma sometimes in the Afro-Caribbean community, and not just in the Afro-Caribbean community. Generally, some people don't like taking tablets. And I can understand that, but they work. So talking about therapies, you have counseling, you have cognitive behavior therapy, you have things that actually affect the gut mobility, like or cramps like buscopan, mebeverine. You can have, in the case of functional diarrhea, you can have loperamide and things like that. So there are things that you can have, but antidepressant or anti-anxiety medication forms a huge part of that treatment. With regards to chronic fatigue syndrome, again, cognitive behavior therapy is at the forefront of that. But also recently, there are immune modulators. They are immune modulators that are like biologic agents that are being, only specialists do this. And it's very much in the experimental stage, but I know people who've had it with some measure of success. It's still an area of ongoing, things are still being built up in that area. So immune modulators there, and then that can be used to do that. Fantastic. So Faye is reminding us that we have a session on faith and medication, etc., on the 4th of December. I'm putting it in my diary. We don't want to miss that one. Okay. With regards to fibromyalgia, the treatment is they respond very well to prednisolone, to a steroid. So this has been established. Some of them respond to tramadol, which is a particular painkiller. And someone's put on the chat that medications have their own issues. Most medications have some side effect or the other, but most of them are also equally safe. Even paracetamol, when not properly used, can give you side effects. So every medication will have some of its own side effects, but by and large, most medications are safe to use. Let's be clear, there is a very stringent method of approving medication here in the UK. I cannot speak for my brothers across the pond in the US, or indeed in the Caribbean or in Nigeria. But here, there's a very strict process of approving medication. You will not be prescribed medication unless it has gone through a very stringent process of safety. And I know I have a patient who has been on antidepressants for 22 years. She was a CEO. She functioned very well. She came to me because she was thinking, I'm retiring now. Do I still need to carry on my pills? So sometimes it doesn't work for everyone, but I'm just saying that these things are there, and for us to take advantage of it and to make use of it as they come. All right, I think I will end here. Surprisingly, I have spent quite a bit of time, and I thought I had a short presentation to give. Well, thank you very much. We'll be happy to take questions. I see some of my colleagues online. So please throw your questions out and let's begin to talk about it. Thank you. So somebody is asking a question that medication has its place, but it can create other health issues. What kind of health issues are we talking about? Does the person care to elucidate or expatiate? And they said, personally, they prefer natural alternative methods. Okay, that's fine. Everybody's entitled to their individual choice. That's perfectly fine. And there's no harm in that. Absolutely no harm in that at all. Do
Morning,
what you are
Dr.
convinced
Joe.
to do.
Or afternoon, well, it's not afternoon yet. So thank you so much for your talk. I'm sorry I missed the beginning of it. I will be logging on and having a listen to the first part of that. So for those of you who don't know me, my name's NGozi. I'm a pediatrician and I help to support the health hours on Saturday, and today I was a bit late. So I'm really pleased that Dr. Joe got stuck into this really interesting and really important topic of psychosomatic disorders. And you've given us a flavour of a few disorders that are, and psychosomatic really means, I'm sure you explained this at the beginning, the effect of your psyche on disease. And you've given us some really good examples where that seems to have a really strong link. But that is not to say that it doesn't have a link to all sorts of other disorders. What would your view on that be? And the reason why I say that, Dr. Joe, just before you answer, is that I think every week that we have our health hours, we'll have questions first of all, people's differing experiences of that very same disorder. Like last week, we had lots of people log on for our fibroids. And we had people with experiences from saying that fibroids were completely debilitating to where it didn't really affect their life that much. And then there'll be people who say, well, if only you. So as if you can take controls in some way of your disease. I think that is in part, but not fully. As you said, medication is also very important. And I think one of the things that you might want to explain is the effect of your psyche on disease.
Thank you, NGozi. That is a very loaded question. So I think I kind of said this at the previous talk where I said our mind plays a very large part in everything that we do. So in the same way that the brain organically controls our organs and the different functions of what's happening in our body, the mind is also linked to what's happening in the different parts of our bodies. Now, I won't have time to go into this as much as I would like to, but the mind can play tricks on you. So this is why, for example, you cannot depend on your emotions to function on a day-to-day basis. Let me just give you a very simple example, right? Recently, my alma mater were talking about having a reunion, and it's been about 25, 30 years since I went to school. I know I look young. Thank you very much.
I know. I would have said maybe 10, Dr. Joe.
Now, on the group chat forum, people began to recall things that had happened. Everybody remembered it in a different way. And then we said, hang on a minute, but these things, we all experienced it. How come we're all remembering it differently? So the theory behind remembering is, for example, I was listening to a very erudite psychiatrist. He said, sometimes we remember what we like to remember. And sometimes, you know, just as an example, sometimes the mind, we put away things that are traumatic, difficult, we push them aside. The other thing as well is that in terms of our memory, the way the memory works, we remember what we remembered the last time. We don't remember the actual event. That's why if someone's telling a story, by the time they say it for 10 years, the story has changed severally. The person may not even remember what they actually said. So the mind has a huge role to play in how our physical, how everything is affected.
There's a question here, just before you go into that. There's somebody that's asking, something like migraine,
yes.
Is it classified as a psychosomatic disorder?
Very good. So one of the symptoms that I said is that you can have headaches or migraines as part of it, but you have a separate medical entity called migraines, which exists on its own, which is not a psychosomatic disorder. There's something going on there. Mm-hmm. There's something causing it. There's something that, you know, but it's actually under the psychosomatic disorder because most people who suffer with migraines have some sort of a trigger. Stress, poor sleep, relationship breakdown, things like that. If it can be caused by what's happening in your mind, then your migraine is a psychosomatic problem. Why is it, for example, that certain migraines work very well with, you know, sumatriptan or other triptans or other things like that? It's because there's something going on that they found out that there is a constriction of certain arteries in the brain, certain parts of the brain. If you give a vasodilator, if you give something that opens up those arteries, your migraines become better. I personally have treated a lot of people with migraines, giving them migraine preventative medication, and they've become better.
Okay, so there are lots of questions in the chat, so I'm going to go through some of them. But just before I do, I think a really good example to illustrate psychosomatic disorders, and that's the effect of the mind on disease. We're not saying that they're not, some of these diseases are not important, you need to take your medicine. But when I was a medical student, a psychiatrist told us a story of somebody who had asthma and they were in a hotel and they woke up feeling really, really bad, and they felt that they need to get some fresh air to try and help their asthma. So they went to the window and they couldn't get it open. So they smashed the window and the fresh air came in and he felt much better and he went to bed. When he woke up in the morning, he found out he had smashed the mirror. He hadn't smashed the window, he had actually smashed the mirror. However, the effect of him feeling that he must have had that fresh air coming in when he hadn't made him calm down and feel much better. Yeah. And that to me was a really good example of the way the mind can affect disease. Now, there is no doubt that this man had underlying asthma, but at that point in time when he was so panicked, what he really needed to do was calm down. Yeah. So there is undoubtedly, because we've run these sessions for almost 18 months now, the effect of we had a really good session about the effect of religion, your psyche as well. And I think it's important for everybody to understand that you need to be in the right frame of mind when you're thinking about your own body and your own disease. However, there's some diseases that will need medication. So
thank you, Ngozi. I'm seeing a lot of stuff in the chat about medication.
Oh, you're about medication. So I think you've covered that in a sense that there is a place for medication, but there's also a place, like the story I've just told, about sometimes when somebody says to you, calm down. Now, we can't beat things like blood pressure with just calming down, and sometimes that needs medication. So I don't think that this session is to ask people to stop taking medication, but to try and use other methods as well, as you've described, to try and put yourself in the right place. You know, they talk about what do you think about mindfulness?
I think mindfulness has its place. I think it definitely, you see, the thing is, I did a session, not on CAHN, on stress. And many of us underestimate how important the troubles that internal troubles that we have, how they play on us and how they affect our physical and mental well-being. Mindfulness absolutely has its place. The more settled you are peacefully internally, the better you're going to feel on the outside. That's my strong opinion. And I think all these things have, you know, their different places. I'll give you an example around this. We started referring patients, the funding has been cut now, this is a while back. We started referring people to do flower arrangement. And in that class, they would play very light, soft music, sort of like a mindfulness thing. And all they were doing was flower arrangement. These people suffered with a lot of anxiety, a lot of depression. About 50% of them came off medication. Some of them came off medication because they got so much better just by being involved in that. So mindfulness has its place. And I feel it's all part of the therapy that we can offer.
So there's a question here about, and it's a really important question about knowing where to claim for benefits if you are affected by some of these conditions. I think about 6 months ago, we had another specialist about fibromyalgia, and it was really, I was really touched by some of the things he said, because he described lots of families not knowing how to get access for disability benefits, and fibromyalgia is one of those conditions that you can. So I think someone's saying, how would you go about supporting people or signposting people to get support for a condition like this?
Okay, so the first thing is you want to go to the Citizens Advice Bureau, your local Citizens Advice Bureau, and start from there. You can also get some support from your local GP. Now, I know that not every GP is as supportive as some others, but they're supposed to be your first port of call as well. There are also societies, like you have Alzheimer's societies, you have all these societies. It depends. See, it depends on your locale. So I'm in sunny Rochdale, where it's always nice and sunny, and I know all the services that are available there, and we know where we can signpost people to. But I also know about Manchester. There are services that you can do. So if you have problems with benefits specifically, start with the Citizens Advice Bureau. They will then signpost. They have all these records, and they would impartially signpost you to where you need to go, the forms you need to fill, and all the websites. But your GP can also have that information and can help with that.
Thank you. Thanks very much, Angel, for this question. She's saying that a member of her family has fibromyalgia, and she's currently laid up with a crisis, and she's really grateful to you, Dr. Joe, for bringing up this really important subject. And she's asking whether there are culturally competent specialists who can help to deal with this. I think Black women that have, and Black men that have this condition, because there is a perception, one, it's very difficult to diagnose, that you should just get on with things in a sense. And so many people with this condition will have gone back to their GPs, have gone backwards and forwards. And so having someone who recognizes that, you're not a sort of strong Black woman and that you need to be sorted out is helpful in these conditions. So do you know any specialists? And And I think when she says culturally competent, people who are used to working with Black patients. And also, I think the other important thing she's put in the chat, are there any trials and any links to COVID-19 and long COVID?
That's a triple barrel question right there. Well, first of all, thank you for your kind comment. I don't know a lot of culturally competent organizations. I do know a lot of culturally competent specialists. The problem is they work in different areas and they're all under NHS. Most of them don't do a lot of private work. One of the things that we're trying to do with CAHN at the moment, there are talks ongoing, is to try to put together something. I know there's a couple of people who are not necessarily in the leadership, but parts of the membership of CAHN, who are trying to put together something like a Black-led mental health organization. That's still very much in the offing. But what I do know, like I said in my presentation, is the counseling, the mental health department of CAHN is very well equipped. If you speak to the people there, they will take you through the process, and then they can signpost you to different individuals. Some people have actually been signposted to me, and some of my other colleagues, and I've been able to see them and speak to them. So we make ourselves available for that. In terms of trials, immunosuppressants, it's a very widely known. There's loads of different ones. Many of them are still very much in the trial stages. Many of them have a lot of side effects and things like that. But that's an area that if you want links, I can provide links later on for recirculation so that you can go into that. Also, with regards to long COVID, there are a lot of research that has been done so far. And again, that area of research is ongoing. So please, if you want links, we can send that across to people as well. The good thing about medicine is that we're not sitting still. There's a lot of research going on with regards to these psychosomatic disorders, as well as research for long COVID.
Thank you very much, Dr. Joe. Diane, thank you for your question. And you've asked about what's the difference between psychosomatic disease and comorbidities?
Okay, thank you, Dion. Like I said at the beginning, psychosomatic disorders are disorders in the mind that have physical manifestations. Comorbidities are things that are actually there. It doesn't have anything to do with the mind. Comorbidities are things like you can have asthma that causes chest pain. You can have diabetes that causes peripheral neuropathy. You can have hypertension that gives headaches. So those are comorbidities that you get, but there's a direct link to a physical health problem. You can have a colonic polyp that is giving you abdominal spasm. You can have diverticulitis that's causing you abdominal pains. You could have an infection that's causing you stomach trouble. Those are comorbidities, and they're very different to psychosomatic diseases.
Thank you. Let's see. For migraines, I think we've already addressed this question about whether it's a psychosomatic disorder, but there's another one that was, can migraines be linked to underlying health issues?
Absolutely, they can. Migraines can be linked to, when you say underlying health issues, what do you mean? Because they can be linked to depression, okay? They can be linked to underlying stress. They can be linked to high blood pressure. It could even be a brain tumor or an aneurysm. So locally, we're developing a protocol locally where if patients who have, especially young patients under the age of 45, who have presented so many times, they get a brain scan straight away, because we don't want to miss out on, like I said, with regards to psychosomatic disorders, it's extremely important to rule out an underlying health problem before we then say that this is a psychosomatic disorder. So it could well be that that's the case. So my relative had a brain tumor, and she was being treated for migraines.
Mm.
So.
Yeah. Okay. Thank you. That's an important distinction to make then. Okay. Well, thank you so much. Again, as usual, I learn from all our sessions, and they're really helpful for me, even though I've got a medical background. Psychosomatic disorders are not part of my day-to-day purview with the patients I look after. And I look after babies. So this has, as usual, been a really excellent session and excellently delivered as well. So thank you very much, Dr. Joe.
Thank you.
So I'm going to hand you over to the CAHN team for them to tell us what's coming up in the next few weeks. Thank you for listening, everybody. Yeah. I'll hand you over to the CAHN team.
Yeah, thanks, NGozi. I was wondering whether we dealt with the case study. So someone sent a case study. I'm just wondering if Dr. Joe can respond to that.
Sorry, what was the case study about?
Okay, it was earlier on. Sorry, I'll just give you some of the main points. It's somebody who's been suffering with migraine for a number of years. It's progressively getting worse, and it usually lasts for a few days. It's reached the point that they're so debilitating that this.
Oh, I saw that. I saw that. Yes.
Did you? Yeah.
I think that the individual needs to. We need to chat about that. It's not. It may not be as straightforward as they think. There are a number of questions that are not being answered. Have they had a brain scan? Have they had an MRI scan? Have they had certain tests? Have they looked into certain things? What migraine prevention or prophylaxis have they used? You know, is there a family history of migraines? Are there other associated problems? Do they have high blood pressure? Are they overweight? So you can see it's not just, you know, unlike NGozi, I need more information. NGozi is brilliant and a genius. I need to ask a few more questions to get to where I need to go to.
No, I did think, although there was a specific question, I did feel that you sort of covered it in the main in terms of what you can offer in a session like this, because it's really difficult to give very specific feedback because you've got all these questions that as somebody who sees people with this will have to clarify before they can offer.
I'm happy to chat with the individual. If they want, they can go through the mental health, the counseling department for CAHN, and they can reach me and we can arrange something. I'm sure we can make that happen.
Oh, thank you, Dr. Joe. That's really helpful. I'm sure this individual, if you're still here and listening, will take up that offer. Thank you so much. Another shout out for our brilliant doctors. Okay, back to you,
massive thanks, Dr. Joe and Dr. NGozi. So I have put in the chat box on the Friday, 26th of November, we have a suicide awareness workshop. It's certificated, although it's free. So, and there could be potential opportunities, for you to go on and become a trainer. Well, to have a trainer course, so you can be, training others, and it's free. So please book on and share. But also our Healthy Hearts is back on Tuesday evenings because it's more tailored one-on-one. It starts at 5:30 till 7 o'clock, and then we have the physical activity between 7 and 7:30. But if you have any questions, for any of our health hour sessions, as you know, it's every Saturday. Feel free, drop us an email, either health@cahn.org.uk or info@cahn.org.uk, and we will put you in touch with, Dr. NGozi, Dr. Joseph, and all the other amazing doctors who give their time week after week. And so just to say massive thanks. And if you need any support from our, counseling team or any advocacy support, then by all means call or text, 077 100 22382, or just email help@cahn.org.uk, and we will be delighted to help you. We always live stream these sessions, so I will encourage you, go back onto our YouTube, channel. You see the link there and share it with your family and friends. But once again, massive thanks, everyone, and enjoy the rest of your weekend. And we will see you on Tuesday. Thank you.
CAHN Health Hour. Giving Black health advice.
Get informed today to have a better, healthy tomorrow.